Good morning. It's a pleasure and honor to introduce Professor Paul Kessler, who is currently Professor and Chair of the Department of Anesthesiology, Intensive Care Medicine and Pain Medicine of the Orthopedic University Clinic in Frankfurt. He's been a professor since 1998. His clinical expertise focuses on regional anesthesia. He's co-authored over 100 peer-reviewed papers, review articles, case reports, and book chapters. Since 2009, Professor has been the chairman of the German. He's chairman of the German Task Force of Regional Anesthesia, and from 2009 to 2013, he was the board member of the ESRA, and since 2014, he's a German zone representative in the ESRA Council. Over to you, Professor.
Thank you very much for the nice introduction. So my topic is updates on anticoagulation and regional anesthesia, what really matters and what not so much. In the next 15 minutes, I can only focus on some specific issues which I think are important for us. I have nothing to disclose, and this I think is a nightmare of every anesthesiologist. This was the attempt of a high thoracic epidural for cardiac surgery, and after the operation they turned the patient and they found a massive bleeding. Fortunately, this has no consequences for the patient, no neurologic damage. We know all that the risk of bleeding is worse for the patient if we do a neuraxial or near neuraxial blockade, and for most superficial blocks, the consequences are not so tremendous. When we know from case reports and from case series what are the risk factors for neuraxial hematomas. We know in orthopedic patients the incidence is higher than in the other patients. Removal of the catheters is a leading cause for epidural hematomas, traumatic puncture, but also anticoagulant therapy is one of the major risk factors for epidural hematoma. More and more of our patients will have now taking some kind of anticoagulant therapies. These are the group of patients with coronary artery disease or with a coronary stent. They will take for lifelong thrombocyte inhibitors. We have the other group of patients with a high risk of thromboembolism, for example, a patient with atrial fibrillation, and they need to take vitamin K antagonists and now the new oral anticoagulants, and this also for a lifelong. And we have the group of patients who are taking perioperatively some kind of thromboembolic prophylaxis like low molecular weight heparins and also the new oral anticoagulants for major knee and hip surgery. The problem for us is that especially when patients taking the thromboembolism prophylaxis, the standard coagulation tests are not impaired, they are normal, and that's a major problem. And also patients taking antiplatelet therapies, the normal number of thrombocytes is normal, but the thrombocytes function is impaired, but we normally don't measure with our normal tests the thrombocyte functions. So it's very important before we do a neuraxial to examine the patients for a history of anticoagulant drugs. And this was also the reason, I think, more than 20 years ago, when the low molecular weight heparin were introduced in the United States, that in a very short period, more than 20 epidural hematomas with paraplegia occurred, and this was the start or the beginning of the recommendations. And nowadays, I think we have a lot of international and national recommendations regarding patients with regional anesthesia and anticoagulant drugs. Important for these recommendations regarding the time intervals with stopping these drugs and doing the blocks are not based, the knowledge are not based on studies, but only based on the pharmacokinetics of the drugs. And we think it is safe when patients taking these drugs in a prophylactic dosage to wait 2 half-lives of the drugs. And if the patients are taking these drugs in a higher dose, in a therapeutic dose, we have to wait 4 or 5 half-lives. And we should also increase, if patients taking a prophylactic dose, these half-lives when there are patients with a renal insufficiency, or if patients taking a combination of anticoagulations. So you also have to wait a longer time before stopping the drugs and doing the blocks. Here you can see the NUARCs which are available just right now, and I will just only focus on the half-life, and you can see the half-life is a little bit longer compared to the low molecular heparins with a half-life of 6 hours. So the half-life of these drugs are higher, and I will also recommend focus on the dabigatran, and you can see this drug is mainly eliminated by the kidney, and if patients have a renal insufficiency, the drug effect is prolonged. And from the AORA recommendations, we see or we know that we have to wait 3 or 5 days between stopping these drugs and then performing our NUAXL blocks. You can see this is a little bit more longer than the 2 half-lives I mentioned before, probably based on the fact that these drugs are new and we don't know exactly how to deal with the drugs, and this is a very secure attitude. And up to now, there are only 10 published case reports of epidural hematoma with these drugs, and you can see 4 of these could be prevented because some of the patients took several anticoagulants and the time interval was too short between stopping the drugs and doing the blocks. The other group of anticoagulants we have are the antiplatelet drugs, and for us only important are the COX-1 inhibitors and the ADP receptor antagonists. And we have to differentiate between reversible antiplatelet drugs and irreversible. We know the COX-1 inhibitor aspirin and the NSAIDs, but more important are the ADP receptor antagonists, clopidogrel, prasugrel, or ticagrelor. Aspirin is a lifelong therapy in patients with coronary artery disease, and we know up to a dosage of 300 milligrams, you don't need to interrupt or to stop the medication of aspirin and to doing a block. So if a patient is taking aspirin up to 300 milligrams, you can continuously use the drug and you can do your block. So if you take a higher dose, more than 300 milligrams, so aspirin is an irreversible platelet inhibitors, so you have to wait not the 2 half-lives, you have to wait the regeneration time of the thrombocytes, and this is 7 days. The same also applies for piroxicam. On the other side, we have a lot of reversible inhibitors, the other NSAIDs like diclofenac, ibuprofen, or indomethacin, and in these drugs you can see after 24 hours the full function of the platelets is restored. So again, also you don't have to stop these drugs when patients are taking these drugs. And also we have other NSAIDs as the COX-2 inhibitors. They have no effects on aggregation and they do not influence the coagulation, and also acetaminophen or metamizole. This seems to be also safe drugs and they can be continued when you are planning a NUAXL block. Clopidogrel, of course, is an irreversible platelet inhibitor, and you have to wait at least 7 days before stopping the drugs. And also the other ADP2 inhibitors, you have to stop between 5 and 7 days, and then you can perform your NUAXL blockade. I think this is a very dangerous publication from 2010 showing 300 patients for a vascular surgery limb, and clopidogrel was stopped 1 day before, and it was started again 1 day after the operation, and the epidural catheter was in the patient for 3 days, and then it was removed without any stopping of these drugs. And in these 300 patients, nothing occurred, no epidural hematoma occurred, but I think this is a very low number, and we should not recommend now from these low numbers that this is a kind of technique we should follow. We should always follow the recommendations of the national societies or international societies to stop clopidogrel at least 7 days before performing a NUAXL blockade. This is now my personal view of these drugs, of these anticoagulant drugs. When you have an urgent case, patient is coming and need an urgent case, and patient has now taken aspirin and clopidogrel. Every kind of new axial blockade is forbidden in these patients. But what about the peripheral blockades? And I differentiate between superficial blocks, deep blocks, and interfacial blocks. And you can see the two stars. The two stars means you can do these blocks probably when you are an experienced ultrasound-guided fellow. Maybe for the superficials and for the interfacial blocks, it's possible when you're taking these two drugs, but you shouldn't do even an ultrasound-guided peripheral block, a deep peripheral block. When patients taking clopidogrel alone, also any new axial blockade is not recommended. And again, if you do an ultrasound-guided block, you can do, in my opinion, a superficial and an interfacial plane block, but you should not do a deep peripheral block. Aspirin in the low dose is no contraindication for everything. And aspirin and the thromboembolic prophylaxis, if the patient under aspirin is now undergoing an operation, again, you cannot do a new axial blockade, but you can do, I think, a superficial and interfacial block again, as well as probably a deep peripheral nerve block. But again, this is my personal view on this topic. This is not recommended by any of the societies. What about now, and when we look at the peripheral regional blocks, not at the new axial blocks, what about the anticoagulation in these patients? The most serious complications are reported in the literature when we do, or when people has done a lumbar plexus block. You can see it here. There are even some death in the literature after some psoas block. And also, the psoas block is done in a very vessel-rich area, and these are data from the German network of regional anesthesia, including more than 40,000 patients, and you can see the rate of bloody tap is the highest when you do a lumbar plexus block. That you have to keep in mind, and therefore, I think the recommendation is absolutely correctly to handle a lumbar plexus block with the same restrictions as we handle new axial block and also the same as we do paravertebral blocks. But you can see also, if you do only a peripheral nerve block or a peripheral catheter, like a femoral catheter, major bleeding can occur. But this is the reason for this is because the catheter was removed after 3 or 4 hours after subcutaneous low molecular heparin were given. And this exactly after 3 or 4 hours, you have the maximum effect of these drugs. And you should also keep in mind what is the maximum effect time and the half-life of these drugs before you remove your catheter. There are only rare recommendations regarding peripheral nerve blocks and anticoagulations, and normally you can find it at the end of all these recommendations in a very short chapter. But these are recommendations, but they are already very old, from 2005, and you can see all these recommendations differentiate between superficial blocks or deep blocks, or between easy blocks and advanced block, and you can see for many of the superficial blocks, there are no restrictions performing these blocks in anticoagulated patients, but deeper blocks or more risky blocks should be done on an individual risk-based ratio. You should explain these patients, or when you think there's these patients with a severe COPD or something like that, and you don't want to do general anesthesia, you want to do an operation in a block only, you can say these patients, okay, there is an increased risk of bleeding, but we use it with ultrasound and we are experienced, and I would recommend we try to do this block in a peripheral block. Then the patient is willing, you should always get a written consent from the patient. And exactly, the psoas and paravertebral block have the same restrictions as that we have for the new axial blocks. What about when we do now peripheral blocks with ultrasound guided? You know, with ultrasound guided, we see in the patient, we see exactly what happens, what is on the way from the skin to the target, and we know we have good data showing that the risk of a vessel puncture is significantly reduced compared to nerve stimulation when we use ultrasound. And the question is, if we do an ultrasound guided block, do we have a higher, is it more safe for our patients? We have no data on this when patients are anticoagulated, but I think mainly it depends on the person who is doing the block. You must be experienced. It's not enough if you have a good ultrasound machine, you know how to use the ultrasound machine. And I think when you are experienced, you can use also an ultrasound guided peripheral block in anticoagulated patients. And up to now, we have a few case reports of ultrasound-guided blocks in highly anticoagulated patients. You can see a femoral or a sciatic nerve block, or a sciatic nerve block for the lower limb again. And this was uneventful for the patient because you could avoid any vessel punctures and any major bleeding. What about the new truncal blocks? So far, there are only a very, very few recommendations or no recommendations in chapters in these official recommendations of the societies, because these drugs are very new. Nearly every week we can read in the literature about the new truncal blocks. But this is a statement of the German task of regional anesthesia regarding the TAP, the rectus sheath, the PEC, the radius, quadratus, and erector spinae. And you can see the statement is ultrasound-guided puncture during anticoagulation is possible. This is a very vague formulation, but I think it's a very wise formulation, because it gives you the chance when you are experienced ultrasound, you can do it based on the individual decision to do a block in this individual patient. So I will come to my last slide. What is important for us when we do regional anesthesia in anticoagulated patients? I think obligatory in patients with anticoagulation is that you have to follow the national or international guidelines from your country. You also should keep the substance-specific time intervals, and if you go below these time intervals, you must be very careful and you must explain it to the patient, and there must be a real serious reason why you go below this time interval. You should do an atraumatic puncture, not a traumatic puncture, which is sometimes for the new axle not so easy. We heard yesterday a lot how difficult it is in specific patients, but also older patients with osteoporotic spine. In these patients, the puncture itself can be very challenging, and you should avoid any several punctures in these patients. You should do it always when you have an abnormal coagulation. You should do it peripheral guided or a central block, always based on the individual risk-benefit analysis. Bring this block, these patients, a real benefit, or should I abandon this block and give a general anesthesia? And you know, all the recommendations from the society don't give you lower thresholds for the coagulation test, for the lab tests. So in our department, we have the borders, the lower limits of thrombocytes is 100,000, and for the PT is 70, and we recommend a normal APT. You should caution in patients who are taking combinations of anticoagulations, as I mentioned before. This is an increased risk, and normally you should not do any kind of new axial block in these patients. Peripheral blocks with ultrasound guidance are possible, in my opinion. And you should also be very careful in patients with renal insufficiency, because in these patients the effect of the anticoagulant is increased and prolonged, and all of our older patients will have a renal insufficiency. So you must be very careful, and you should check the renal function always before you do central blockade. And thank you very much.